First of all, thank you very much for the invitation. I was here for the first time ever in Louisville yesterday, and I'm embarrassed to say it was also my first time in the state of Kentucky, so I can't imagine I've made it this far in my life and never been here before. But it's delightful, and I had just a wonderful day yesterday with Andy Patterson showing me around. And then this morning I got to see St. John's Center and the clinic where the Healthcare for the Homeless program is. And it's the work that goes on here in Louisville is stunning. So I just wanted to say a salute to you all for if you're involved in that. And to those of you who are students and medical students, get involved with these guys. They're really amazing. I am going to, though, try, if the world works here, to just give you a little bit of tour. I was trying to think of this as a lecture in humanism, and every once in a while I feel less than human, so I want to be a little careful in this. There's something about the drive getting through medical school and professional school, nursing school, et cetera, where sometimes the work becomes so much we lose sight of ourselves and how do we take care of ourselves. And I am more guilty of that than most. But there's always, you know, serendipity in your careers, and I was going to share with you just some of the serendipity that happened to me along the way. That is kind of, every time I kind of think I'm getting good at something, there's always something to stand up there and show you that you've still got a lot to learn. And it's this journey of learning that's really spectacular. And I know for those of you medical students, thank you, because Sarah told me, I know there's a test like at 1 o'clock, so for those who have to leave early, please, you can leave, and I will not be offended, having been down that route many times myself. This is the oldest picture I have in my medical library of stuff. And it's a picture that I took of a patient of mine, a woman who's in her gurney with her daughter, when she was in the emergency room at Mass General Hospital. And this was in 1983 or late 82. And I remember taking a picture there because she wanted me to get a picture of her little girl. And we used to call her a street urchin. She called herself a street urchin, and she was really kind of cool. And you can see she's got this kind of very fiery, feisty look in her eyes. And what is stunning to me about this picture are a few things. One is the woman in the gurney there was the first patient we had at Mass General Hospital. She was my patient who had AIDS. This was 1982, 83. And we knew a lot about what was going on, but we had not yet seen frank cases of AIDS. So I finished medical school in 1982, and we hadn't yet, and we heard about AIDS coming, but it was in San Francisco and New York, but we hadn't seen it in Boston yet. And this was our first patient. And we didn't know anything of what was going on. We didn't know what caused it. We didn't know how to treat it. All we could do was try to do the best we could with the infections that people were getting because they were so immunocompromised. And so I had gotten to know this woman pretty well. And I used to get furious with her because right now she's so sick. She's in the emergency room, but she has something that if she had come, you know, a couple weeks earlier, I might have been able to make an intervention and sort of keep it from getting very bad. And what I came to realize, if you look at that little girl, she won't, no matter how much we tried, and the nurses tried really hard to lure her away from her mom, she wouldn't leave that gurney. She hung on and was going to stay there. And what she had known from the past was that every time her mom came in and got sick and got put in the hospital, she would be placed in foster care for the temporary time that her mother was in the hospital. And she hated that. So she did not want to leave her mom. And her mom, on the other hand, as mad as I might have been with her, was saying, I don't want to get sick. I don't want to go to the hospital. When I go to the hospital, I lose my child for the time. She was also struggling with a cocaine addiction, which I had understood. And she was also petrified that if somebody got into a cocaine addiction, she might lose her child permanently. So there was a lot going on when I realized that the medical problem, in this case, she had early pneumocystis pneumonia. And we can sort of early enough, even then you could treat it a little bit. But she was now so sick that we were way behind the thing. And we had to admit her upstairs. And remember, this was the first time at Mass General Hospital in its 200-year history that we actually admitted the mother and the child together. It was kind of an interesting, good outcome. But what I learned out of that was that I was not very good at caring for patients who, and by the way, she was also homeless and living in and out of motels, et cetera. But the social situation and the surroundings behind that were overwhelming for me. And that prescription that I had to give her some Bactrim for her pneumocystis was really not going to treat anything right here. There was way too much complicated stuff. So I had an inkling then as a resident that we were okay inside the hospital and inside the confines of our clinics, but the social determinants of what's going on for the health of our patients was really pretty overwhelming. So let me frame shift to, or fast forward, I hope, to as I was finishing residency, and more serendipity, I had decided I wanted to become an oncologist. I wanted to take care of cancer. I had loved it. And I had spent a lot of time on the cancer ward at our hospital, grew to love taking care of people in that setting. But when I was a senior resident, the city of Boston got a grant to do a healthcare for the homeless program through the Robert Wood Johnson Foundation. And the community of people that were putting that together, there was a community of stakeholders. I mentioned this yesterday to those who, oh no, let me show you this first. That the issue in Boston at the time was kind of unusual, probably a little different than you see here in Louisville, but maybe in other ways more similar. We have a town, Boston is a small town, 2 miles by 2 miles, that has 12 major teaching hospitals, 3 big medical schools, lots and lots of medical stuff. In this map, there are 26 community health centers. In addition to all those green things, which you can really see, those are major teaching hospitals like Brigham and Women's Hospital, Mass General Hospital. There's a lot. And then what you can see is that the adult shelters in our town, which are those yellow triangles, are clustered in the downtown area. And the red dots, which are the family shelters, are pretty much in the neighborhoods. And in our world, there are 2 different ways to go. There's family homelessness and there's adult homelessness, and they're very, very different. Okay, and the treatment and the models of care you have to do are very, very different as well. I want to talk today just about my experience with the adults. I'm going to leave the family part alone for a moment. So if you look at just the yellow triangles, those are the places where we do most of our clinics. I was a resident. At the time, I had no idea what was going on. I was just taking care of people in the emergency room and in the hospital. But what struck me is when I first looked at this is, why would you need a healthcare for the homeless program? There's so much medical stuff there. Shouldn't we be able to take care of homeless people in our mainstream systems? And the answer was that our emergency rooms back in 1982 and 83 were getting deluged with homeless people whose illnesses had just gone so advanced they needed an emergency room. There was no primary and preventive care. So the Robert Wood Johnson Foundation was trying to get communities to get together and sort of galvanize interest in communities to reach out and take care of that thing. Now there's a problem that came up because what they said was that there needed to be a coalition of community stakeholders to work with the mayor to come up with what the model of care should be. And I don't know what your experience has been in community work around here, but we have a bad habit, I certainly did, when you're in a medical environment to decide what you think is going to be best for the community and go out and try to do it. And you rarely get the community involved to tell you what to do. And when they tell you what to do, we rarely do it anyway. However, this is 5 of the 88 people that got together to try to hammer out our program. And not to bore you, I just want to show you that they had really clear ideas about how they wanted to be treated, which were very different from the traditional way I was thinking people should be treated. And I show you all of them because all but one of those people were homeless, living on the streets or in the shelters, but very invested in putting this grant together. And it was an experience for me to learn to listen to a community, and we had to, by fiat, listen to the community. And what they insisted we do was stay part of the mainstream of the hospital. So they wanted a program that was not separate and isolated from the rest of the community or from the rest of the health system. They wanted it to be part of the hospital system, but then to get the people in the hospital to reach out into the community on their terms, not on our terms. So this is Boston City Hospital, Boston Medical Center, which is our biggest hospital in caring for poor in Boston. I love this picture because I took it, you probably can't read that, but it says Boston City Hospital, and there's a little white ladder coming, and the man's coming to change the name to Boston Medical Center. It was the last day of a very rich tradition of a city hospital now becoming a merged entity to become Boston Medical Center, which still is a phenomenal place. But we have a clinic there every day of the week, which the community insisted on doing. And then we also have a clinic at Mass General Hospital, which is a private hospital. The city hospital was public, and this was a private hospital, where off to the main entrance there on the right, we have a clinic every day where we had to be sort of grown as part of the hospital. But the real thing that people were asking us to do was get out to the shelters and into places where homeless people were. And, uh-oh. I'm overheating something up there. I'm not sure what it is. Hope it's not my words. But this is an example of a shelter in Boston. This is Pine Street Inn, which is the largest shelter, believe it or not, not only in Boston, but in all of New England. And it sleeps about 800 to 900 people a night. Okay, it's a big place. There's a separate building for women on the other, just the other side of that, where 125 to 150 women sleep each night. And it's a really robust program with lots of services. They've been involved in housing. They have over 1,000 units of housing now that they manage and take care of, as well as the emergency shelter. So it's a really phenomenal place. We have actually a clinic right in there that goes every day of the week, 12 hours a day. And it is, if I were to write a history of homelessness, I'd include them, because I think they were, back in the early 1900s, were having very creative ideas about how you should do some of this. But what they were looking for was, we had to be part of the hospital, but they wanted us to get our clinicians into the shelters, something which you probably all know now. But back then didn't exist, okay? And it was kind of radical, and I wasn't sure that was something I really wanted to be a part of. The other shelter that I would just share with you is two of the big shelters in Boston. This is, the city of Boston has a shelter called Long Island Shelter. It's on an island in the middle of Boston Harbor. And it sleeps also somewhere between anywhere from 500 to 800 people per night. And it's in an old building on the middle of an island in Boston. It's actually very beautiful. And this building itself used to be the TB treatment facility for the city of Boston, for the county actually. And it was where you could bring people out into to have open air in those days when you have lots of air. And because we had good public health treatments for managing tuberculosis, it had pretty much closed down about 20 years before. And the mayor, who couldn't find a neighborhood in town where he could open up a shelter, because neighborhoods can get very testy about that, as you know, said, this is the easy thing. We can put people in our empty building, bust them out there every day, and we can have a shelter that relieves some of the pressure. And this is all in the early 1980s, when we were feeling the numbers of homeless people growing, okay? So the irony of that, which you should never lose, is that as soon as we move people into these abandoned TB treatment buildings, and if you notice, many mental health hospitals were emptied out, and we would make them into homeless shelters, the problems that we ended up encountering when you see a homeless population are like tuberculosis. So it's really kind of interesting. We emptied out the treatment facilities, put people in, and what did we get? Tuberculosis. So never lose that little irony. This I just want to show you, for those of you who don't know Boston, this is where the shelter is out here. And you can see people actually line up at Boston Medical Center, and they get bused all the way down here. It's about 12 miles out to the thing. That's the city's shelter. So talk about a creative way to approach it. The nice thing of it, and I don't want to belabor this too much, it is a very beautiful setting. And this is, if you're out in the shelter, this is the back door of the shelter looking out over downtown Boston. So for many people, they feel it's just an escape, and a beautiful escape to the countryside. For other people, they feel like they've been exiled, and they feel like they're on Molokai. You know, it's really far away from downtown. So I just want to, the other things that I had to learn, remember, I'm coming out of the hospital, I finished my residency, I really want to be an oncologist, I don't really want to be doing this, but I figured I got forced by my chief of medicine to do it sort of for a year. Forced is a bad word, I shouldn't say it like that. He called me in when I was a senior resident, and for those of you who are going to be doing your residencies at some point, when your chief of medicine calls you in and asks questions, those are rhetorical questions. The answer is yes, whatever they say, okay? So he said, would you do this for a year? I said, absolutely, and he delayed my fellowship for a year. So this is what I realized. These are homeless people standing in line to go into Pine Street Inn, and the doors of Pine Street closed at 7:30 in the morning, and they didn't open again until 3 to 4 in the afternoon. And people would stand up. It was first come, first served. So they would be standing in line, and this picture was taken in the relative early afternoon. It's a snowy, cold, and kind of wet day, and people are just going to stand in that line in the afternoon. And then when they get through that, they get in line to get their meal ticket, their bed ticket, which is the first thing you need to get. So survival on the street is often regimented standing in line, waiting for the thing you need. And once you get your bed ticket, you can then go and get your meal. So then there's another line for your meal. So I was horrified. I used to think lives of homeless people were just kind of chaotic and no rhythm to it. But it's highly ritualized for many people. If you're going to survive, you've got to learn how to get through these lines well. We also learned the other way. We had clinics that we had designed to make really comfortable for people in the afternoon, in the morning and in the afternoon at the hospital. The mornings were great, but nobody came to the afternoon clinics, and it was because they had to be here to survive. So we learned the hard way that we had to really do clinics in the morning, so let the afternoon go, and then do clinics in the evening after people have gotten the things they need to survive. So one of the other hard things you'll learn is that when people are struggling with poverty, healthcare needs are sort of way down their priority list. So we have to nudge them up ourselves, because when they're struggling to survive, they can't be thinking about an appointment 3 weeks from now, or what you should do for your hypertension, which you can't feel. Now, for the nurses, I'm learning, I think all these red shirts that I'm seeing are nursing students. Is that correct? Okay, so I want to make a real point to tell you about your profession, which is really the profession that taught me everything I know what I'm doing now. But when I started at Pine Street Inn in 1985, the Pine Street Inn had a nurses clinic. It was the only independently licensed nurses clinic in the country. They were on the cover of the American Journal of Nurses. And I walked in there thinking, I just finished my residency at Mass General. It's my first job as a doctor. I'm a full-time paid doc to go work in the shelter. I thought they were going to be thrilled to see me. But nurses can be hard, okay? And my oldest sister's a nurse, so I know the look that I got when I walked through the door. And they were not happy to have a doctor coming out of one of those hospitals at all, okay? And they made me sit down in one of those chairs like that guy's sitting at. And they read me the riot act about how they had been doing this for 15 or 20 years without the help of any doctors or hospitals, thank you very much, and that if I would just sit back, they would teach me what I would need to do. And you have to remember, my last rotation in the hospital was the senior resident in charge of the ICU. So I came from this world where people were being sent from all over the world to get taken care of. We had dials and everything. I'd go 6 blocks down the street, and the nurses are saying, sit back, we're going to show you what we're going to do. And I'm ready to do stuff. So my oldest clinical picture is this one. And Barbara McGinnis, who is the nurse today, my real hero, she said, look, you came out of the wrong training thing. You're going to have to relearn this. And so for the first 3 months that I was at Pine Street Inn, I had to put my stethoscope down. I couldn't do any doctoring stuff. I had to soak feet. So you can imagine I'm going from the ICU, high tech, to soaking feet, thinking all the while that I had made a big mistake, okay? This is not the kind of clinical thing I was looking at. But Barbara was trying to point out that when we're training in our various programs, life is really fast, really insane. You've got to see a lot of people. You've got to, if I'm in the clinic and I've only seen 4 or 5 people in an hour or in an hour and a half, somebody's going to knock on my door and see if I need help. Is there something the matter? You've got to get moving, okay? And we have to like talk to people, get their chief complaint, make a diagnosis, treat, get them moved on to the next thing. And Barbara said that's an utter failure when you take care of homeless people and people that have been, whose lives have been marked by fragmentation and loss. You're not going to win, you're not going to get anywhere unless you can set up a relationship with them. It sounds kind of trite or trivial, but it's the key to all that we do. So she was trying to get me to slow down, so I had to soak feet. I couldn't ask this gentleman any medical questions. I could just say, can I do anything else for you? How can I help? Something like that. And so I was soaking his feet as well as a bunch of people. And I knew him from the emergency room. He had been in dozens of times to the emergency room, and we had put in his chart that he had paranoid schizophrenia, treatment resistant. So that's what we had labeled him as. We really wrote that in the chart. I think that would probably be unethical now, but that's what we did back then. And he would always look at us. He'd be picked up by the police. He'd be brought into the emergency room. We'd try to do something in an exam room. He'd look at us just like that. We'd recommend all these treatments for his legs and everything else, and he would just never do anything. He would leave and be gone. So I'm soaking his feet, and after about a month of soaking his feet, he looks down at me, and the first words he ever says to me, he said, I thought you were supposed to be a doctor. And I said, I am. And he said, well, what the hell are you doing soaking feet? And I said, I don't know. I have no idea. But I'm trying to get into it. And he sort of looked at me kind of funny. And then a few days later, he actually asked me, he said, Doc, while I'm soaking his feet, can you help me sleep? I can't sleep at night. And it was the first question, the first real request he had of me. So I said, sure. And I talked it over with some of my friends, and we gave him a little bit of Haldol to see if it could calm him down enough and get him some sleep. And so I gave him that. He took it for a couple of nights, and he came in, he said, it's pretty good stuff, but can you give me a little bit more? I only sleep about 3 or 4 hours. I'd like to sleep longer. So we upped the dose we went from a half a milligram to a milligram, and it worked like a charm. He was really happy by it. And it turned out after that, he then started asking for other medications, and it wasn't treatment resistant at all. He actually got on psych meds after that, went into a group home after 25 years on the streets, and he stayed in a group home until he died about 5 years ago. And it was all my learning that, our system was pretty resistant to being able to treat him because we only had one way to throw things at him. But as you got to know him and let him do it on his terms, it worked. And he took his medicines every single day. So it was really the opposite of treatment resistant. So I have to remember, every time I look at this picture, I remember the nurses. I owe a huge debt to the nurses who understood a whole lot more about how to take care of people than I had learned in my training at the medical school and in the hospital. Now, there were lots of other things that I'll share with you that are clinical that I have gotten good at, but I wasn't at the time. These are lice, as many lice as you'll probably ever see in all sizes and shape. And you can see that they sort of live, interestingly, on clothing. That's where they stay most of the time. They just get onto the skin to bite, but they live on the clothing. So when you look for lice, make sure you look in people's clothing. Don't look on their skin, okay? And I was horrified when I first saw that because I didn't see that much in the hospital, but the nurses showed me how to take care of it. It was really no problem. Interestingly, from a medical perspective, lice we used to think of as an infestation that was kind of annoying and made you itch all the time, but not serious. But it turned out in the early 1990s, we started seeing a recrudescence of a thing we used to call trench fever in World War I and World War II. And it was caused by an organism which is called Bartonella. And we hadn't seen much of it. And it turns out Bartonella is a little bacteria that lice carry, and when they bite you, you can get the Bartonella infection. And it causes heart valve infections, and it causes your joints to get infected. And there were several outbreaks that you can see in the New England Journal. This was the first real article in the New England Journal that I saw about the medical problems of homeless people. You see things about mental health issues and substance abuse issues, but this was real serious medical stuff. And it was an outbreak in Paris and in Seattle of septic arthritis and endocarditis caused by Bartonella that was caused by lice. So it was kind of an interesting, you started to realize that maybe this wasn't so trivial, the medical stuff you're doing there when you're in care. And then I had to learn a lot of things that I kind of, had to go back to humility on because I thought I knew my medical stuff really well and I was going to teach people there what I was going to go. So this is one of the nurses, and this guy whose name is Amerigo came in one night to me in 1985 and he said, "Doc, you got to do something. I can't swallow my vodka." And I said, "Well, tell me what's up." And he was this delightful guy. He said, "I haven't been able to swallow food for like months, but I could always get my vodka down. And then yesterday, I've been trying to swallow my vodka. It won't go down." And so, it turned out, not surprisingly, when we did the workup, he had a huge esophageal cancer. It had grown large, and had been closing his esophagus for months. And at this point now, it's now completely closed. He can't even get fluid down. So and it wasn't treatable. It was, we needed him really to get into palliative and end-of-life care. And so what we did was put in a tube so we could feed him by bypassing that, which you can see he's using there. And then I worked like crazy to get him into a nursing home. He's one of 2 or 3 people I decided I'm going to get him a nursing home bed where he'll be safe and taken care of well. And so I did that and sent him to the nursing home. I was really triumphant about this. It was a beautiful one in the area town that he likes best, looked over the water. And then I came back to Pine Street the following week, and I'm walking down the alleyway to go into the shelter, and he's sitting there with all of his friends, and he's got this tube that he's got in his stomach there, and he's pouring his bottle of vodka right into this like this. And I was going to kill him, what are you doing? And he looked at me and he said, "Doc, don't leave me alone." He said, "I went to that place. I've had 2 people say the same thing. And nobody talks to one another. They're watching TV, and I don't want to be there. If I'm going to die, I want to die here with all my friends." So we had to kind of put up the white flag and realize this was the way he wanted to be cared for. And so that's Sheila, one of the nurses at Pine Street, one of those really amazing nurses. And they would do tube feedings for him and take care of him. And he stayed there until the day before he died with the people that he knew. Now, in my mind, that was all wrong. But as I grew to understand this, people will tell you what they need and want. And we have to do our best to kind of accommodate that. But I still think of him drinking in that alleyway, laughing with his friends, pouring the vodka down his tube. And then, this is a picture I showed yesterday if you were here, but there are other things I had to learn that the lesson for me was I thought I was good at medicine, but obviously I was making some big mistakes. But there's a time when medicine and public health come together and we realize we're all in the same boat. And this was a guy who was brought into me by the staff at Pine Street, not the nurses, the staff, the people who just work outside. I've learned now whenever they say something's wrong with somebody, I turn the volume way up because they see chaos all the time. And if somebody emerges above the chaos, something is going on. Anyway, they brought this guy in. They said, "Doc, he doesn't look right. We've known him a long time. Can you help us out?" And I was really proud of myself because I could tell this stuff here is scabies. You can see where the scabies has gotten under the skin and going along. So I could say, well, he's got some scabies. I thought I had gone there. And that thing in front of his ear is a basal cell carcinoma. And he obviously smokes too much. He's got a little bit of a lot of COPD, and he's got pectus excavatum for those of you doing anatomy. And he's otherwise, saying, look, and he drinks too much, obviously. He looked at me and he said, what is all the fuss about, doc? I feel fine. Will you just let me go? And I did his vital signs. I listened to his lungs. I did everything, and it was all normal. His vital signs were normal. His lungs were clear. And I said to the staff that brought him in, as well as to him, I said, I know we got to try to help him stop drinking and stop smoking, but I don't see anything acute going on. But if you're really worried about him, bring him back again in a couple days. We'll take another look at him. Big mistake, okay? So 2 days later, the same staff brought him back in, and we have a little x-ray machine at Pine Street Inn, and this was his x-ray for 2 days later. And for those of you who don't know tuberculosis very well, this is like classic third world tuberculosis. Cavitary tuberculosis, for the medical folks, that's a right apical pneumothorax that you can see up in the top there. And he's lost lots of volume in his lungs. But when you put a stethoscope to those lungs, they are clear. They go in and out, and it's really clear. And he did not have a fever. Turns out that what the staff had been noticing was that he was getting up at night and coughing a lot and having a lot of sweats. But he did not have a fever when I saw him. So it turns out he became what they call the index case, or the source case, for what then became 99 cases of active pulmonary tuberculosis in the shelter over the next several months to year. So all of a sudden, I'm looking at this one person and realizing he lives in a community of 800 other people, and those lungs were like that probably for 6 months. So he's been coughing up in the shelter tuberculosis all along. The other problem we had is it was a multi-drug resistant tuberculosis, which means to treat it, you needed 4 medications every day for 18 months. Okay? And it was before, for those of you who follow the history of tuberculosis and multi-drug resistant TB, this is not AIDS related. This was in a group of people who were primarily drinkers, none of whom were immunocompromised. So we had this now dilemma of how do you get 4 medications to everybody, these 99 people, for every day for 18 months, or risk spreading this to zillions of other people. And it was a real public health dilemma. And I realized I was useless at doing this, okay? So it was the Department of Public Health from the city, the state, the nurses, our team, and some outreach workers that we all had to get together and come up with a plan. So I remember real community organizing about how do you cope with this. And it was my lesson that when you start to get into the community, your partners are your strength, and we are useless unless we can work with them. This is another picture of Barbara McGinnis, who was the TB nurse actually at Pine Street, and Yoshiko Van, who is the nurse practitioner with me. And those are I thought, just so for those of you who now know everything is digitalized, that's back in the days when we had these big x-rays that we had to carry around, and it was really a nightmare. And then it turns out this was drug-resistant TB that became the model for what you will now see done in third world countries where they do directly observed therapy, and it's for multi-drug thing. But this is our team. Here's what we have to do, because everybody who got their tuberculosis would leave the shelter and go out. Okay, they would never come back because they said the shelter's a place where I got TB. I'm not going back there. So we would have to find them every day. And Mark is the caseworker on the team I worked on the right, and Ursula is the nurse on the left. They would get on their bikes. They would go find these folks and give them their medicine every day. That was what we used to call, it was in the days before, but it turns out to be what they say called directly observed therapy. Give those medicines, watch them take it. And 96 of the 99 people got treated over the whole course of the time, which was a remarkable testament to sort of the city of Boston's ability to gather people together. And it was a lesson for me, as you can imagine. The other thing, for those of you who are medical, it also changed my mind. When you get tuberculosis in your mind, it turns out tuberculosis is a great imitator of everything else, and you have to keep it in your differential all the time, like I should have done when I first examined that guy. But this is a picture of a man who had been discharged from the hospital with cirrhosis because of alcohol. And he was being treated for alcoholic cirrhosis, Lennox cirrhosis. But when he came in to see us, we started realizing, you know what? This was TB peritonitis. This was not cirrhosis at all. And it needed a completely different treatment. So keep that in your mind. Tuberculosis can be prostatitis. It can be, it can do all sorts of things that in the old days we would have seen, but we rarely see anymore. This was somebody I thought had a fungal infection of his skin. And when we did the biopsy, this was not a fungus infection. It's TB of the skin. So you start to realize it's in all these things that made me thinking I was good. All of a sudden, I realized I'm still a real learner in this world. We had ultraviolet lights we had to put in the shelter. And then we learned finally that the most effective thing we could do to monitor TB was to have the staff who were up on the floors where people were sleeping monitor coughing. So the people who cough at night are the ones that you really want to go find. The PPD screening and the X-ray screening didn't really work very well because you're trying to do it to everybody. But if you could focus those people who were high at risk, it was amazing. So we've actually had, while TB has taken off in shelters around the country in the early 90s, we actually had a decrease and got it down to almost zero because of the way that epidemic had helped us change our system. So I want to tell you about, so our job, remember now, was to be part of the mainstream system, but get out to places where homeless people were, because we didn't want, the theory was if you wait for them to come to you, it's often the emergency room they're going to come to, and they're not going to get primary preventive care. So we thought we were doing great. We had our docs and nurse practitioners and PAs working in teams in about 40 different shelters by 1990, and it was great. It was all sort of coordinated. But this man, whose name is Jim Green, walked into the office one day, and I was in the office. He came in smelling like horses. I'll never forget this. He smelled, and I thought I'd share this story with you since you're in the epicenter of this world. But he came in and he said, where the hell are the people supposed to take care of homeless people in town? And I said, well, that's us. What's going on? And so he dragged me out. He turns out to be a guy who is a horse owner, and he runs a little thing in what's called the backstretch of Suffolk Downs, which is our local thoroughbred racetrack. It's just the other side of Logan Airport. I had honestly never been there. They have 1,500 thoroughbred horses that race basically September through May. It's a winter race course, actually. It's changing a little bit now. And Jim came to us and said, would you come out? And he dragged us out to see these folks. And we went out, and I remember the first day I lived there, he said, you got to see the pageantry. And you guys know this all too well. That's Pat Day, who happened to be there that day, who I think at the time was the winningest jockey on the circuit. And I was kind of impressed by the, by the pageantry. But then behind the scenes were the people that take care of the horses in the back barns. And there turned out there were 500 people working hard, hours and hours per day, all living in the back barns and taking care of the horses and shoveling things out, who had no insurance. They wouldn't take a takeout. And because they got paid under the table, if you try to say, would you come in for a clinic appointment, they would never do that because they'd lose their whole day's wage to do that. And frequently, somebody else will take the job from them because that's how. And this is a man named Tommy who he's almost 80 years old when I took that picture. He'd been on the racetrack since he was 18. I'm sure you know this. He just had grown. He couldn't read or write, but he knew horses inside and out. And Shirley is one of the horse owners there, and they were doing that. But you get a flavor for. This is a bad picture of one of the barns with the horses looking out, and then across from that was another one of the stables, and in each one of those little stables there, or corrals there would be 5 or 6 people living in the stalls with hay in the bottom. And I was stunned. This is Boston. I didn't know it even existed. And Jim pointed out to me that this happens like this across the country in thoroughbred racetracks. It's how the industry keeps things going. And these folks had no health care. And so he said, why aren't you coming out to do it? So we ended up doing I think if I have a good picture of it. So this is the barn where his horses were. And this is Trish, our nurse. So we actually got an old, a trailer, and we took over one of the trailers, made a clinic out there, and we now do the clinics out at the racetrack. And our staff loves it because these are people that work really hard, never come to you with a complaint because they're just tough. They only come if they say they have a back pain, it's usually something broken. It's like really serious. And our staff loves taking care of them. But what you have to do is go see them while they're working most of the time because they won't even stop to let you see him. So this is Tricia, our nurse, doing a follow-up on this guy who had lymph nodes in his chest. And it's just a stunning place where we had no idea. So I don't know where around the country the other racetracks are. I'm sure in the very, very wealthy ones things must be done. But in the sort of the other racetracks, I suspect there's a need for care of those migrant and homeless workers in a big way. I took this, they won an award, and I took this picture. I went to Saratoga Springs, which is where there's another racetrack, and Jim and Shirley, who are right there, got an award, and I'm blanking on the lady's name, but she owns Secretariat. What's her name? Penny, whatever it is. Somebody yelled that out. Chenery, that's it. But I thought that was pretty cool. And then Secretariat, the movie Secretariat came out soon after that. So I thought, yay, we're at least up on one there. So here was the goal. These are the goals that our community put together for us as a program. So they wanted us to make sure we provided continuity of care. And I keep emphasizing that because when I think of the something missing every once in a while, in the old days, I would think we didn't have much technology, but we had a lot of continuity. As we get more technology and more sophisticated, continuity goes away and we have all this spread out. But for some groups, I think the continuity becomes absolutely critical. So that our folks wanted continuity from shelter and street right through the hospital. They wanted us to deliver care in teams. And this is 1984. And the reason they said that, which I was emphasizing to some folks we were talking before, is that the people we care for have a hard time making relationships. When they do make a relationship, it's really hard to fracture that relationship. So if you come out and you spend 6 months working somewhere, like I was going to do, spend a year taking care of homeless people, if I then leave, and I'm the only one taking care of them, they've lost their continuity and somebody else has to start all over again. So what they wanted was teams, so that a team would get to know somebody. So if any one member of the team left, there was still continuity for the person you were caring for. And so I've grown up on teams, and it's kind of interesting as I watch the new changes in healthcare with the patient-centered medical homes, the team is now becoming an important component. So I've been thinking a lot, I wish I could write this down, but I think when you go out and take care of very marginalized populations now, like homeless people, vulnerable homeless people living on the shelter of the street, what you will see early and before anyone else are the weaknesses in our mainstream healthcare system. So usually when you see things that are the problem with them, you can guarantee it's going to show up in the mainstream system a few years later. I'll give you another example. As we got ourselves seeing people in 40 different shelters and on the streets and the racetrack, we realized, God, we were doing better at getting access, people having access. But if I was seeing somebody in the Pine Street Inn on a Monday night, but they had been seen Friday afternoon by one of our docs at St. Francis House, I would have no idea that that happened because the paper chart would be over at St. Francis and I'd be seeing them here. So in 1994, we went to Mass General Hospital where they have a laboratory of computer science and they were working on computerized records. And they said, and this wasn't because we were smart, it was just because we were desperate, and said, we need something to help us coordinate care now that we've got all these access. So they developed for us with our staff getting involved in an electronic record which went live 17 years ago. So we've had one single record electronically for everybody for 17 years. That was 5 years before our hospital went to an electronic record. So you can see where sometimes these funky populations can teach you what you really need to know earlier than that. Anyway, the last thing which I want to spend a little time sharing with you is this concept of respite care. Our community stakeholders wanted respite care. I asked them, what does that mean? I don't even know what respite care was. I'd never seen it written down that way before. And for those of you who are into policy and Medicare, turns out there is respite care paid for by Medicare, but that's if you're taking care of a very sick elderly or very sick person at home or something, and you yourself need respite from taking care of that. Medicare will pay for somebody to come in and take your place and give you a little space. So this is respite care for homeless people, though. And this is, let me show you what I mean by this. And I'd love your input if you can. So it turns out that homeless people, when they were finished with the hospital or when they were in the emergency room, don't have a place to go to recover or to get cared for. Most of us can go home and you have a family there, or you have a home health aide or a visiting nurse or whatever it is. But if you're homeless, you don't have that. So the shelter people were furious that hospitals were sending very sick people back to the shelter. Remember, the doors are closed from 7:30 in the morning till 3 in the afternoon, who had to then walk around all day while they were still sick. So they wanted us, as a new program, to come up with a place where people could stay and be watched over. I thought of it initially as like the infirmary when you're in college. When you get sick in college, you can at least go somewhere and someone's grandmother takes care of you with chicken soup and everything else, okay? But this was our original respite program. It opened actually in 1985, this month, September of 1985. And we had 25 beds in a bigger shelter where we could take care of people. And Betty Sneed here is our respite aide, and she's taking care of a man who had just had a stroke. This man has heart failure, he's on a bunch of medications, and the man over there had been in the hospital and lost part of his foot to frostbite. What our goal was to have nurses and our doctors there as much as we could in the shelter so people could have a safe place to stay, they could stay all day, and we would do the medical and nursing care for them. And it was a kind of a sleepy program back in the beginning, because for those of you who are not around then, lengths of stay in the hospital were very, very long back in the 1980s. So for example, that man who had frostbite of his foot had stayed in the hospital almost 3 months. Okay? The man with heart failure had been in several weeks. Now, most of those things that we take care of, you stay in for just a couple days or maybe not even at all, and then the care is shifted to the home setting. But for people who don't have homes, that has gotten very acute. So we realized over time, I'll show you the kinds of things that we had. So this is, oh, that was interesting. So this is one of our other aides taking care of a man who just needed to have his feet elevated, but he couldn't do it when he was walking around. It's a man who had that external fixator on his foot, and you can see where that could be really tough to handle when you're outside. And this is a guy who had been in and out of the hospital with he has these venous stasis, which you can see here, lots of brawny edema, and then his skin keeps breaking down and it gets infected. You come into the hospital and you needed a week of IV antibiotics. And we found if we could bring him over to the respite unit and keep his leg up and do the dressing changes, we could pretty much keep him out of the hospital. So that was a kind of low-level stuff that we would do back then. But then what happened in 1985 and early 86, AIDS hit the homeless community. When I started in 1985, we did not know a single person in the shelter system of Boston who had AIDS. And in that fall, we started seeing the first cases of AIDS. And this was one of our first gentlemen that had AIDS. And it was a disaster back then because we had no treatment. It was really awful. He had kidney failure now, and he's on ambulatory peritoneal dialysis, which the hospital wouldn't let him stay in anymore because you can usually do this at home. So he came to our place so that we could do that for him for the time he wanted. We thought it was pretty outrageous. And I threw this in here because this is my, the other thing I have to remember when I'm talking now is in 1985 we had our first, or 1987, we had our first computer in the program. We had one computer. It was one of those Mac 512s. It was like this big. I think it was 512 megabytes was its entire memory. And that's what we wrote down. I remember that was the first little study we did of copying down who had AIDS and was diagnosed with AIDS when they hit the shelter system. And if you notice their survival, the only thing I wanted to point out, if you were diagnosed with AIDS in the shelter, you lived a few months at most. Okay, it was really disastrous. And this is a man who had had AIDS. He was shot in a drive-by shooting. They did an exploratory on his abdomen and they closed it up. And then when he was about 7 days later, he did wound dehiscence. You know, you've heard about when wounds dehisce. This is it. So his surgery, which had closed up his abdomen, just opened up. And the way you now have to take care of that is let it close up primarily. You can't sew that back up. So you have to take care of that with dressing changes, which you will all know. And he had no place to go. So he's got AIDS and he's got this terrible wound, and we had to hold him in our set. So it turned out as things got more and more intense, we moved to a bigger place. This is in 1992, we moved to this building, called it the Barbara McGinnis House after thing. And then we started getting a lot more intense in a level of care that we could provide. We had an architect who came in who was homeless, and he did this. We opened on Valentine's Day of 1993, and he did this kind of three-dimensional heart, which hung over the elevator for years. I thought that was always pretty cool. Then we could do things like this. A woman who has lots of issues going on, bad emphysema, COPD, can do okay with all these machines. She's also now got esophageal cancer as well. And so we could take care of her. She doesn't need to be in the hospital, but she can't do this in a shelter and has no place to go. This is kind of an interesting thing. This is a halo, which all of you know. This man had broken one of the vertebrae in his neck, and he needed to be in that halo for 6 weeks. They let him stay in the hospital 3 days. And I remember watching this as I saved this. This was a discharge summary from the hospital. And it gives you a flavor for what we were dealing with back then. He said a 46-year-old bicyclist was struck by a car, and you have to hear this, with, quote, impressive damage to the car. Okay? So you're wondering who they're really concerned about. And if there were medical residents here, I'd challenge you to know what this is, with the loss of cartilage both in the ears and in the trachea. And this is what's called relapsing polychondritis. And this woman was homeless, and every time she fell asleep at night, her trachea would collapse. She'd have a respiratory arrest, end up in the hospital, usually the ICU. And there's a treatment for that we could do, but we had to bring her into McGinnis House to break that cycle of hospitalizations. And then frostbite. I don't know how much frostbite you see here, but it gets cold here, so you probably see it. But I thought I'd give you I had not seen that much. Most of the frostbite in our hospital went to the surgical service, and I didn't see it. But this is early frostbite. Looks just like a burn, okay? And that's somebody who actually did really well. That was early enough that it didn't get bad. This is somebody who was in the emergency room at 7 o'clock in the morning, discharged at 7:30, and we found him at 9 o'clock, and that frostbite happened sometime between, in that hour or so, an hour and a half. And that's now much worse frostbite. You can see it's bloody and beginning to get a little necrotic. And then this is really bad frostbite. This is an older man who was shoveling snow trying to make money, but he had peripheral neuropathy, couldn't feel his feet, and he let them get so cold that they got that. And you can actually see, these toes are all necrotic. You can see that it's beginning to demarcate, and they're going to self-amputate is what will happen on this. We had, let's skip over some of these. I could give you other things of frostbite, but let me skip over. And then the other thing we started to realize we had to do a lot in our respite program was end-of-life care, because many of the folks we were caring for, as they got sick, they had no family, they had no friends, and they had no place to die. And we weren't really very well equipped to have people die with us, but we decided we would not abandon. As it turns out, some of our folks, we tried to send them to nursing homes, for example, just like that first people, and they feel like you're abandoning them, so they wouldn't let us do that. So this is one of our guy who had lived on the streets for 25 years. He was a Vietnam veteran, and he now has head and neck cancer. And he's being prepped for what is going to be what they call a commando procedure to remove most of the stuff in his neck. And we kept him at McGinnis House. I have this old picture of me. This is about a month or two later, probably about 3 weeks before he eventually died. But he's now got a trach. They've had to redo everything. But he had no one in the world and begged us not to kick him out of our respite program. This is now just for those of you who ever come to Boston, we've just moved our respite program into this building, which is the old, what's called the Mallory Institute of Pathology. So for those of you who are doing any studying of Mallory Weiss tears or Mallory bodies in the liver, this is where they discovered all that. It used to be the pathology department for Harvard, BU, and Tufts. But we now have our 104 beds of sort of 24-hour respite care in that building as well as our clinic, but I'll spare you that. But it's also the old city morgue, so I like to throw this picture in because we had to renovate it as it was in 1929 for that. But in that building now, this is Tommy, the guy I showed you before, who is 80 years old. And it turns out he got cancer. He's out at the racetrack. His only home is a racetrack. So we brought him in for end-of-life care. This is his roommate, who is 37 years. Tommy's 84 now, and he's 37. And he has a lung cancer with brain meds. And Tommy is dying of neurological cancer that was pretty complicated. But since he had no place to go, we tried to, in our respite program, take care of him. And I remember Tommy was this remarkable guy who knew horses really well, was really simple, said, just don't make a fuss over me. When I die, just throw me in one of the dumpsters at the track, all that kind of really homespun stuff. And when he was really sick, what we would do is bring him out we would put him in a wheelchair and bring him out to the track. And it was really a delight to see, because you'd bring him in his wheelchair to the barn, and the horses that he used to take care of would go crazy, because they hadn't seen him in a long time. And then he would get this real joy out of seeing these fillies that this was a filly that he totally loved and knew all about. And it was just the kind of thing that picked him up. So he stayed with us for about 4 months before he died of his cancer. And just to share with you, some of the things that I used to struggle with is, do you take pictures or do you not take pictures? So I've been showing you a lot of pictures that if you notice, most of the ones I took in the old days were only of feet and hands and stuff like that. I never took pictures of faces. But this is a woman who has tried to convince me to do otherwise. And her name is Carolyn. And what she did, she got, a long time ago, got hepatitis C from a blood transfusion. And she was a street lady. She lived on the street, always was in rags. And she kept drinking. She wouldn't stop drinking. And so the combination of hepatitis C and the alcohol meant that she progressed to end-stage liver disease. She had bad cirrhosis. So we tried to get her a liver transplant. But to get the transplant, you have to show 6 months of residential stability and 6 months of staying sober. So we let her stay in McGinnis House, where we could prove to the transplant surgeons at Mass General that she was stable and that we could get urines whenever they wanted that showed that she was not drinking anything. And so as 6 months went by, she called me one day when would page me and said, would I come by and take her picture? Okay, and I wasn't ready for this. And I came by, it was a Sunday morning, and I stopped in and she had gotten all dressed up. Remember, I'd never seen this lady in anything but just tattered rags. She got all dressed up, has lipstick on, and there's flowers in her little styrofoam cup next to her bed table. And so I took that picture and I was kind of stunned. She's actually kind of, stunning in a way. And I brought that picture, I framed it a little bit and brought it back to her, and I was talking to her about what's going on. And she explained to me that she said, I know I've got this big surgery coming up, hopefully, if she was going to get her liver transplant. She said, but I have 2 daughters who I haven't seen since they were 5 and 6 years old each. And she said, they're out there somewhere, but I want to be sure if ever they did want to find out who their mother was or what she looks like, I wanted a picture that they could have to look at. And I was kind of like taken aback, because this is like, this is somebody facing death or facing a terrible illness, isolated even from her own children, but just hoping she could leave something for them to hang on to. And it took me aghast. So I've started thinking a lot about the experience of illness and suffering and dying when you've lost everything. And you see your life as having been either a failure or something else. And that's the profound part that's really hard in caring for this population. There is a lot behind what's going on, in addition to trying to care for people. So it's caring for them, but acknowledging that other stuff. What was interesting to me, though, is I gave her that picture so that she could have, and she had framed. And when I came into work on Monday, this was a Sunday, when I came in the next day, there were 22 people that asked me to please take their picture. And we now have, I'll show you, we now have taken a completely different issue. For many people, a picture is something that they hang on to. It shows them when they're doing well. It shows that they're human beings. You know, and we did this, like this, these are people that asked me to just take their photographs. And so we now hang them in our McGinnis house on the thing there. But you get the flavor. They're just all characters. And so then I changed things. I will ask people if they want their picture or want their portrait. And we frame them all in nice frames. And when people get admitted to our McGinnis house, they'll get upset if their picture isn't up in the portrait gallery. So you have to take that picture and get it up, or you take one down and put another one up. It's really gotten to be out of control. But just to show you some of the other, remember I was mentioning continuity in the beginning, and some of what we've had to learn was how do you stay close and good to the academic medical centers and the hospitals while taking care of a very marginalized population. And my great fear, and I would share this with you guys when I first started, was I had been around long enough to know that most of the docs I knew, including even the nurses who went down to Pine Street, when they went out to take care of very marginalized populations, they rapidly get marginalized by our own professions. So they're looked at as the people that couldn't make it somewhere else, or they dropped out or something like that. And I had a great fear of that, because after you spend all that time training, you don't want to all of a sudden become marginalized by the very profession you want to be part of. Plus, I realized from the people that were caring for us, that were working with us, is that we can look at this as short-term doing good, or you can look at it as, why shouldn't this be a career that people pursue and it's valued and it's accepted as part of our training and part of our, part of what we respect, okay, part of education. So I think one of the drives now across the country is to see if taking care of homeless populations that I would argue are far more complicated than most populations you take care of. They require much more medical expertise, nursing expertise, mental health, substance abuse, and they require a lot of coordination. That shouldn't be something that's marginalized by our training programs or our hospitals. They should be embracing it. So the goal for us is, how do you attract great people like you to come in and choose that as a career? That's something I still worry about. But this is Brad, who's standing up, and he's a Green Beret from Vietnam. Green Berets, for those of you who weren't around for Vietnam, were the crazy guys who went in tunnels, they did everything. They were tough, okay? And he came back and something happened and he ended up on the streets from 1972 on. And he met Charles, who became his street partner and his life partner actually, who was also on the streets. Charles had a completely different background, gone to college, something had happened, and they were both on the street together. And they were one of the first people we got into one of the Housing First programs. We got them in together. And Charles was the very first person I cared for back in 1986 who had AIDS but was a long-term non-responder. He just has never had any trouble with his AIDS. He was the only person I was taking care of. He became part of one of the big studies looking at the long-term non-responders, or non-progressors, excuse me, I'm saying the wrong thing. But anyway, Charles was convinced it was because of his diet and what he ate and everything else. And about a year ago, his CD4 count started to fall. And I got worried. It had been 20-some years and it hadn't budged. And so I told him it's time to get on medication. He really needs life-preserving medication. And he looked at me like I was crazy. He said, Doc, I've known you a long time, but it's my diet. I'm going to just up my diet. I can do this. I can do it. And despite all our protests, he came in and called one day, and he wasn't able to breathe very well. We went out to get him, and he had this overwhelming pneumocystis pneumonia. He was in the ICU for a few days and then died. And I was crushed because I figured there was something we should have done to do something. And Brad, who had been his partner for years, was now alone in the house, and we would go to visit him, and he was losing weight, looking depressed, and we thought he was having a terrible grieving reaction to the loss of his close friend. And we ended up finally getting him to come into the clinic, did an x-ray, and he had a huge lung cancer that had gone metastatic to his brain and to his chest. And within about a month of Charles's death, he died as well, okay? And I was like, stunned. But when I was looking through my pictures, one of the old ones here, this is a picture I took 25 years ago of the two of them when I first met them, and they were out at that shelter that I told you was in the middle of Long Island. And there's Brad. This is like still late 60s kind of look. But they decided in 1985 at Long Island Shelter to get married. And I can't tell you what a gutsy call that is, because shelters have all sorts of politics. Most of it is a little bit, it's either way left or way right. And so they took untold grief, but Brad was a Green Beret. You did not fool around with him, okay? But he got married, and the two of them, I remember looking at this and saying, this is kind of, this is really gutsy, but what's going to happen to them? But they stayed together for 27 years. They stayed together and sort of died, within a couple months of one another. And it was actually a very touching story of two people who led absolutely, they had been dealt the worst hand you can imagine, but sort of stuck with it. And the privilege for us was I knew them through all of those 25, knew them through the whole thing with AIDS, the whole thing with Brad. Brad had several surgeries for neurological things, but it was pretty intense. So I realized it was I was grateful that they let me be part of their lives all that time, when I kept thinking I was only going to do this for a year and quit. So I remember that was the whole thing that had to change in my thinking. So I'm probably going to stop there because it's 1 o'clock, but the thing I wanted to share with you, I think of humanism in medicine, which we don't do very well, and I only do it sometimes on reflection. But there's a lot of stuff. When I have been back in Boston, I keep, the first thing I tell people is that, I went to medical school hoping to do international care and do third world stuff, and got waylaid by being in hospital medicine or something, and I now realize that my entire career has happened within a half a mile of my medical school. Okay, everything I've done is a half mile in any direction. And I think about the poverty that exists in there and the need that people have, that I've realized now, in addition to, we're more like a third world country when we do our care than we are like a first world country. And so there's a huge need for people who are really bright, really good, to get involved in that. And my worry now is I have lots of friends who are doing global medicine now at Harvard Medical School, and we finally realize that global means when you step outside the door, that begins the global part. So competing with that lure to go to overseas countries and third world countries, which is what I really wanted to do and I think is fabulous, I think we should really think of care in the inner city as one of those challenges that we should embrace and grab, and that you should feel animated by and energized by trying to do. And there's a lot of need there, right down the street. Okay, so thank you for letting me sort of absorb your noon hour, and I appreciate my being taken such great care of here in Kentucky, and I hope I can see a little bit more of it before I have to go. But if there's any questions, I'm happy to stay afterwards. I realize it's 1 and you may need to go, but thank you very much. Okay.